Hello and welcome. I'm Dr. Elizabeth Teal. On behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's CMEO briefcase entitled From First Steps to Full Stride, a Lifelong Journey with Lennox-Gastaut Syndrome. Today's program is supported by an independent medical education grant from Jazz Pharmaceuticals. I'm Elizabeth Teal, and I'm Director of Pediatric Epilepsy Program at the Mass General Hospital in Boston. And today I'm very honored and thrilled to be joined by Dr. Tracy Dixon Salazar. And Tracy, would you like to introduce yourself?
Yes, thank you. Hi, I'm Tracy Dixon Salazar. I'm the Executive Director of the Lennox-Gastaut Syndrome Foundation, and I have a daughter who is 31 who has LGS. I also am a research scientist. I have my PhD in neuroscience and neurogenetics. It's great to be here.
Thanks, Tracy. So our learning objectives for today are to incorporate the latest clinical trial data and real-world evidence to individualize treatment plans for patients with LGS, and to integrate a collaborative care approach that includes patient and caregiver quality of life assessments, shared decision-making, patient needs, and long-term care information as part of clinical decision-making for patients with LGS to improve outcomes. So Tracy, if you don't mind, could you get us started by telling us a little bit about your daughter's story through the first few years of her life and experience with LGS?
Yes, absolutely. So my daughter Savannah was healthy and typically developing until she was 2 when she had her first seizure. And prior to that, she had been developing fine, which is pretty common in some of the developmental and epileptic encephalopathies. She wasn't precocious, she wasn't delayed. And then at 2.5, she had a tonic-clonic seizure. We didn't know it was that. We actually thought she was choking, which is how uninformed we were. And then we went home. We actually went home from the doctor with a clean workup, normal MRI, normal EEG, and they said, watch and wait. And so we did, and she had a couple more seizures over the next few months, and we were still watching and waiting. And then she went 6 months without having any seizures at all. And the seizures came back when she was 3 years old, and they came back with a vengeance. She started having hundreds of seizures a day in some cases. I think a good day would be 5 to 10 seizures. A bad day would be hundreds. And you just didn't know from day to day what you were going to get. And she began to fall behind in her development. She really just sort of stopped learning at that point because she was having so many seizures. And we learned at that time that she actually had been diagnosed with epilepsy because we requested her medical records and read it in the chart. It's not something that had been shared with us. We had been calling them spells and episodes, not seizures. So I think that was challenging. And then, as she continued from the age of 3 to 5, she tried a bunch of different anti-seizure medications. And by the time she was 5, she had tried and failed 8 different medications. So she's intractable at this point. And this is when she went in for a full EEG workup, for surgical workup, and she was diagnosed with LGS. So this is when she was diagnosed with LGS. And nobody's born with LGS. We know that now. It's something that evolves over time from early life seizures. But when we got the diagnosis, we read a paragraph in a book that basically said, she is going to have continued seizures into adulthood. She's not going to get control. She's going to have progressive intellectual disability and premature death. And to read that in a book and to have had that conversation to sort of just get a diagnosis was really hard on us. There was a lot of confusion. I remember first we were confused because we're like, oh, now LGS, that's the diagnosis. She doesn't have epilepsy, but she actually has both. She has LGS and she has epilepsy. And then later when she turned 18, we actually found she has a genetic cause for her seizures. So she has calcium channel overactivation disorder, calcium channel mutations. And so she also has that diagnosis. She also has intellectual disability. And as a family, it was nice to know we have all of those. We don't just have one diagnosis. And so when I think back about how the journey could be improved, I really think being upfront with our patients and families and telling them, it's epilepsy. It's Lennox-Gastaut syndrome. Don't shy away from those diagnoses. Yes, it's difficult, but we're adults. We will process it and we will address it accordingly, right? This is how we face it. I also think just being really clear with your family about being able to have multiple diagnoses. And then finally, when they do get a really tough diagnosis like Lennox-Gastaut syndrome, referring families to the LGS Foundation or to a like organization that can really be there and help to educate them, to support them, and to give them the tools they need to cope with this is really important.
Thanks very much, Tracy. And I completely agree, especially with the importance of the LGS Foundation. I think it's really changed the world for a lot of my families and patients on this journey. So then we'll begin with an audience response question to get you all thinking about when diagnostic interventions may be optimized in early stages of LGS. So at which point in the early stages of LGS can diagnostic intervention be optimized? So as we see, the correct answer is B, during initial presentation of greater than one seizure type with abnormal brainwaves on EEG. And I think that this is important. You know, all the years I've been a pediatric epileptologist, I always say that it's not unusual for kids to have more than one seizure type. But I think now realizing that we do have specific therapies which can be more effective for some of these syndromes, it's important to diagnose them as soon as possible. So to start thinking about it, not necessarily to tell the family at that point, oh, I think your kid has LGS or likely has LGS, but at least start thinking, could this be what I'm seeing? Because as Tracy said earlier, it sometimes takes a period of time to really diagnose a patient with LGS after they have onset of seizures.
Yeah, absolutely. We see that it's about 1 in 3 with LGS had normal development prior to the onset of their seizures, and then all of them will have developmental delay in order to get the diagnosis of LGS, right? But it's something that evolves over time, with the most common age of presentation of the LGS being between 3 and 5 years of age. There's certainly outliers, but that's when we see it most. And so you'll often hear doctors say, oh, they look like they're going LGS. And so watching the EEG, watching the seizure types, trying to get seizure control are all really important when you see that unfolding.
Yeah, and I've had discussions with colleagues before that it can take several years to really determine if a child has LGS or doesn't have LGS. And I think that's really emphasized by the latest ILE kind of defining or broadening the definition of onset of up to the age of 18. So important to keep it in mind. So then let's look at a case. And let's meet Silas, who's a 2-year-old male who presents to his pediatrician. The parents' complaint for the visit, and the reason for the visit is Silas has not yet started walking. And he also hasn't started talking, and he also has occasional episodes of pausing and staring off to the side while he's playing. In his medical history, he was born prematurely at 32 weeks, and he had febrile seizures at 6 months of age. So what suspicious features of this case should you pay attention to? And what other features should also put you on alert as a child's pediatrician or primary care? So Tracy, as a mother, what about this complaint would make, especially with you now looking back, kind of your early experience with Savannah not recognizing that initial seizure, what advice would you give to the PCP here?
Yeah, I mean, I think it's really concerning that there was a febrile seizure early on. It's not uncommon to see febrile seizures to evolve into epilepsy at a later time in these kids. And I think these pausing and staring seizures are something that you really want to get a handle on, because if that's happening, if they end up being absence type seizures, then this child's going to start to fall further and further behind in their development.
No, and I agree. And, kind of even though there is a broad range of when kids walk and when kids start talking, the fact that at the age of 2, he hadn't really started walking or talking, then I really have to pay close attention to that, because I think parental intuition is incredibly powerful. So the fact that parents had noticed that Silas would pause and stare off to the side while playing also would make me say, gee, could these be seizures? So then turning to the classification definition of Lennox-Gastaut syndrome. So there are criteria that are really mandatory. And we know this is an epilepsy syndrome with mixed seizure types, but the tonic seizures are really required. And it's also can be difficult because these may only appear during sleep. So sometimes if I'm seeing a patient, I'm wondering, could this be LGS? With other seizure types, they may have the atypical absence, atonic, myoclonic, focal impaired awareness, epileptic spasms, non-convulsive status. And I'm wondering, could this be in the setting of LGS? Sometimes it's really important to get sleep EEG. And if that's not done on a sleep-deprived EEG, then it's done on ambulatory 24-hour EEG. Because it could really help me make it a diagnosis earlier. Yes, this is LGS. And then also the generalized slow spike and wave complexes on EEG with the classic less than 2.5 hertz or 2.5 per second, or a history of this finding on prior EEGs, because as we know, as individuals with LGS age, the EEG changes, and sometimes that slow spike and wave is no longer seen. So if it's been seen on a prior EEG. And then really most of us believe that generalized paroxysmal fast activity during sleep is probably more specific to LGS than even the slow spike and wave. But again, this might not be seen. So just the history of that on a prior EEG. There are alerts, a photoparoxysmal response at low frequencies, maybe consider other, especially with these evolving treatments for genetic therapies, and also greater than 8 years of age at onset. As Tracy said, it can happen, but usually kids start having seizures and developmental concerns earlier than that. And then exclusion for LGS is persistent focal abnormalities without a generalized spike and wave pattern on EEG. Then it's really important to think about what else could I be looking at. As we said, neuroimaging and genetic testing is not required for the diagnosis, but it's helpful evaluating etiology and guiding treatment. And about 50% of infants with a severe DEE evolve to LGS over time, including those with infantile spasms, et cetera. As they age, they will kind of evolve more into an LGS pattern, which makes you think, gee, what am I looking at now and how am I going to treat this?
So some of the things that we see with families is that they don't know that there's more than one seizure type. They'll assume that the seizure that they saw in the beginning is the only kind of seizure. So I think it's really important to explain that, that these other seizure types are not something that you want to tolerate. And even looking back on our journey, we were kept sharing her having myoclonic seizures or atypical absence seizures. They weren't a generalized tonic-clonic, so we weren't counting them as a seizure. It was like a seizure's almost starting, or she wanted to have one, but she didn't fully, or there's big ones and little ones, right? And I still hear this today amongst our families. So making sure that they have that education is really important.
No, I agree. And I think it's the responsibility of the healthcare providers to kind of say, seizures can look like different things. And sometimes we do see different seizure types. I think the ones that families often have the toughest time with are the atypical absence. And sometimes I've had to even show parents the EEG while their child's not responding to them, say, no, it's not that they weren't responding, it's that they were having a seizure. So that's a really good point. So then kind of taking a step back and looking at the core features of LGS, again, it's greater than one seizure type. Again, tonic kind of required, but also typical absence, tonic, atonic drop attacks, non-convulsive status. The abnormal EEG with the classic interictal slow spike and wave, and also paroxysmal fast rhythms, mainly during non-REM sleep. So again, often requiring sleep EEG to document that. Cognitive impairment, the developmental delay and/or intellectual slowing, regression, or disability. And for most, seizures begin early. So most patients that are diagnosed with LGS, the seizures beginning less than 3 years of age. However, seizure onset can occur at any time. And then just let's return to Silas. So being concerned about the developmental delay and also the stirring spells, the neurologist did get an EEG. And as you can see, this EEG is abnormal. So on the left, we see the classic 2 Hertz generalized spike and wave. So the slow spike and wave that we expect to see if we're thinking LGS. And then on the right is the paroxysmal fast activity during sleep. Again, kind of many people are beginning to feel that that is a more specific EEG pattern for LGS and may persist longer than the slow spike and wave. So again, often the importance of getting the sleep EEG. So kind of moving on from Silas to another case, this time with Krista. Krista is a 28-year-old patient with a history of drug-resistant epilepsy. Her seizures started around the age of 2 with drop seizures, generalized tonic-clonic seizures. She was in special needs education throughout school, currently lives with her family. And the reason for the visit today is seizure activity. She's now experiencing 3 to 4 tonic seizures a day, 3 to 4 atonic or drop seizures, and 2 to 3 tonic-clonic seizures per month. Her current medications are brevaciracetam, lacosamide, and clonazepam, and she's clearly refractory, having been on several previous treatments, including levetiracetam, clonazepam, clobazam, phenytoin, carbamazepine, sodium valproate, primidone, topiramate, and VNS. So clearly highly refractory to medications. So let's pause to answer a question. Which of the following is a good first step in the primary care setting to further characterize Krista's seizures? And the correct answer is the REST LGS, which is a tool to basically help diagnose LGS, particularly in the adolescent or adult setting when that early history may not be available. And REST LGS stands for Refractory Epilepsy Screening Tool for LGS. And I think that this is a very valuable tool that kind of looks at the current criteria of both seizure activity, other aspects of the patient, with whatever EEG features you have, and could that help you make the diagnosis? And this is becoming increasingly important, particularly with our FDA-approved medications now specifically for LGS, because in many areas without that specific diagnosis, patients do not have access to these medications. So Tracy, I don't know, kind of through the LGS Foundation, do you feel this tool is pretty well known and used by neurologists and also by primary care providers?
I don't think this is known very well in the community, especially in the adult population, especially because Krista here is 28 years old. But I think there's this idea that assigning a diagnosis like Lennox-Gastaut Syndrome or Dravet syndrome is really meant for pediatrics. It's not relevant in the adult care setting. It's not going to change management. It's not going to help the doctors in any way. And I think the exact opposite is true. I think knowing that you have LGS or you have a patient with LGS opens them up to these therapies that are specific for seizures associated with LGS. In addition to that, it can connect them with their community, which is really powerful. It's a really difficult diagnosis. So having other people who have been there, done that can help you navigate, become educated. You guys in the community, you don't have time in your 15-minute visit to educate on all the different therapies and answer every single question, but we do have time to do that. So I think it's really important, but I think it's a completely underutilized. I don't think people are even looking at the tool because they're assuming from the beginning that they either don't have LGS patients because that's a pediatric disease and therefore and they must all die at 18, I guess, because once they become adults they don't have it, or it's not going to matter if we give the LGS diagnosis, so they're not even looking into the tool. And I would just challenge anybody who thinks that way to actually flip it and look at it, because we know from hearing from patients and families and from doctors who have given the diagnosis that it is really powerful to do that, and it's important to do that.
Yeah, I think it's a frustration that I know the LGS Foundation has. I think a lot of the pediatric epilepsy world has, and the adult epilepsy community, that there are many people walking around with LGS who have never received that diagnosis. And I think it would be good if there was greater awareness of this tool, because I think it can be extremely helpful. I've talked with some of my adult colleagues and kind of just say, if you have a person that comes in particularly wearing a helmet, an adult wearing a helmet that has drop seizures, that person likely has LGS. But having this, which I think is now pretty validated tool to say, yes, now this is pretty good clinical, evidence that this person may have LGS. I think neurologists definitely need to utilize this. I would like to see a world where primary care providers would do that and think enough about the epilepsy. I find that a lot of PCPs are really intimidated by seizures and intimidated by different seizure types. So I'd like to think that one day this tool would be in the primary care world, but it would be great to see it even better utilized in the neurology community.
I absolutely agree.
So then returning to Krista, Krista is finally given a formal diagnosis of LGS after her PCP. So I want that PCP's name so I can refer my patients to them. After the PCP screened using the REST LGS, and Krista scored 11, and referred her to a known specialist for further workup and video EEG interpretation. Now, Krista is still experiencing an average of 3 to 4 tonic seizures a day, 3 to 4 drop seizures, and continues to have 2 to 3 seizures a month. And there again are her medications and her previous medications. So let's see how we can use the SHARE method for shared decision-making to discuss some of Krista's treatment plan. So first, SHARE, seek participation. Krista and her family would like further seizure reduction. Her seizure activity is significantly affecting her quality of life and her safety. The HELP, the H, help explore and compare treatment options. Krista and her family would like to pursue options for further seizure reduction. She's been on a gazillion different medications without effective seizure control. What are the other options she have, both with regard to medications as well as non-pharmacologic therapies? So let's pause and answer a question before we move into thinking about treatment options. Which of the following indicated pharmacotherapy choices would be reasonable to try next based on what we know about Krista? So the correct answer is B, pharmaceutical cannabidiol or fenfluramine, both of which now, as we know, have specific FDA-approved indications for Lennox-Gastaut treatment. Both of those would be worth considering.
And I can't tell you how many times in our community that our families come in. So we have a 12,000 member community. Our families will come in and they have not heard of the newer treatment options. So in very much in Krista's case, where they're on a lot of the older treatment options, treatments specifically for seizures, not necessarily tried in the super refractory LGS community, where you have cannabidiol and fenfluramine, which are new, and other new treatments are emerging, and they're not even aware of these. And I think it's because doctors prescribe what they're used to, what they're comfortable with, but these newer treatments are seeing patients who are achieving seizure freedom, right? And there's always a chance, and we don't want to give up on them. And so I think the number of times we see this in our community is it's quite frequent. And so I think it's important to be really thinking about what are the newer options, what's out there, what can they try now that they have these diagnoses.
And Tracy, do you see that both in the pediatric and the adult kind of neurology communities, or do you think it's more that the adult providers are less familiar with these, again, because they don't see LGS?
I think if you're seeing a pediatric epileptologist or a pediatric neurologist that's at a major medical center, then I think that you're going to be getting somebody who's familiar with these treatments. But we actually looked at health claims data at some point of all the patients who were diagnosed with Lennox-Gastaut syndrome using the codes, and the majority of them were not seen by epileptologists or even neurology. They were seen by general practice. They were seen by people who are not at a major medical center, which is fine. But I think there has to be this increased awareness that it's not just epilepsy. It's not just intractable epilepsy. It's Lennox-Gastaut syndrome. It's super refractory, and we do have new options. And so I think the more we can get the word out, the better. And I think for the adults, especially when they find these newer treatments, I think that the side effect profile is going way down in them in many cases. I know we experienced this in my own daughter. In addition to that, I think that, these newer treatments have been trialed in a population that just has so many seizures that it really can make a difference for families.
Yeah, no, I completely agree. So then going back to Krista's treatment choices and the share way of looking at this. So then we need to assess values and preferences. So for Krista and her family, what's the affordability of the regimen? What's the ability to reduce seizures further and improve, or at least not adversely impact quality of life and daily tasks? And would it be possible to reduce medications currently taking if possible? And after assessing, then reaching a decision, incorporating the values and preferences of the patient and family, along with the latest clinical trial data, real-world evidence to make a recommendation and decision. So Tracy, what other values and preferences do you think are important to a caregiver who's thinking about a different anti-seizure medication?
I mean, I think thinking about the number of medications and the side effects is really important. And a lot of times this assess value and preferences is done without actually talking to the patient family. I know that there are times where medications are not offered because the assumptions that insurance not going to cover it, the family can't afford it, right? But there are paths to get it coverage. Right. There are programs that will assist in paying for the copays or helping get access to the drug. And so I think we should explore those. There's also the constant fight that we're having with insurance companies. I think all of us in the LGS community have learned how to do this, but we're going back and forth with our doctors to get access. So making sure you have that conversation. The other thing I would say is that we've started thinking about the medications in terms of the side effects as being a positive. So one example is with cannabidiol, one of the side effects with that drug was diarrhea. But for the 98% of people in our community who are constipated, it actually has been a positive thing in some cases, right? So is there something you can think about when the side effects? So if they aren't sleeping, so can you put them on something more sedating? If they're sleeping too much, can you not put them on something that's that sedating, right? Can you start to think about the side effects in more of a positive light that might be able to help the bigger picture for this person who has LGS? Is another thing that we've been thinking about a lot in our community, because we don't want them on 7, 8, 9 drugs, right? Which, was the old generation, irrational polytherapy. But now we really want this rational polytherapy and choosing the drugs for their entire profile.
No, and I think your point's a really good one. I think that side effect of cannabidiol, we hear that more often than not, that's a positive side effect of medication. And I think your point also that you really need to, even if a person has a diagnosis of LGS, you still treat that person as an individual living with LGS. And you can't it's not one kind of way fix all. And you really have to look at that individual's, what other issues they have, what medications could help them, what medications would be more difficult for them. So really good point.
Yeah, I think the tendency is to think, okay, we're the neurologist, so we're going to treat the seizures, especially in adult care. But there are so many things that these medications are going to impact. We have GI issues, there's mobility issues, there's sleepiness, right? There's, their overall sleep, there's behavior, right? So to the extent that you can consider those things when prescribing a drug, it'll just make it so much easier for the families to manage.
No, absolutely. So then turning in the next slide to the efficacy of our anti-seizure medications for LGS. And this is a systematic review and network meta-analysis of the different RCTs that had been done. So these investigators took a total of 8 randomized controlled trials with over 1,000 patients, 1,171 patients included, and studied 6 of our anti-seizure medications, all of which have approvals for LGS, including lamotrigine, rufinamide, pharmaceutical cannabidiol, and topiramate. And looking at this scatter plot, basically anything to the right of 1 is good. What you can see is these medications work. Again, the reason we need to make the diagnosis of LGS in patients so they can have access to these medications. And you can see that the medications clearly worked favorably to placebo. And then comparing some of the medications to others, you can see that there is some variation in a theme on some being effective, but we know that these are all potentially very effective medications for individuals with LGS. Looking at safety and tolerability of the profile of these medications, again, from the same review and meta-analysis, you can see that they're all pretty similar. Somnolence is a side effect with, I think, every anti-seizure medication, and then other things, but really pretty favorable side effect profile and tolerability with regard to these medications in this population. Looking down the study group, you can see that there are some potential more significant side effects, especially the fatalities that occurred after approval with aplastic anemia and liver failure. But I think that continues to be, felbamate continues to be an important tool in my toolbox for my folks with LGS. I often find it very effective, particularly in pediatric population, and extremely well tolerated. But important study looking at, we have this group of medications that we know can work in treating LGS, and we know that they also have fairly good safety tolerability profiles. Then just looking really quickly at fenfluramine and kind of singling this out since it was not included in that meta-analysis, but another medication that now has FDA approval for treatment of seizures in LGS, and safety and efficacy from the recent clinical trials leading to its approval. So the design overview here enrolled over 200 individuals with LGS, 146 males, 117 females, both children and adults. So important that this trial and the CBD trial also enrolled adults, because I frequently get asked the question, these medications, do they work in adults? And the median age was 13, but ranging up to 35 years of age. So of the randomization, pretty fair randomization between placebo, low dose fenfluramine at 0.2 mg per kg per day and 0.7 mg per kg per day. And the primary outcome in this study was a change from baseline in drop seizure frequency for fenfluramine 0.7, so the higher dose versus placebo. And as you can see on the right, this trial was statistically significant, showing a more significant reduction in seizures in the high dose fenfluramine as compared to the placebo. So another question for practical considerations, true or false? Pharmaceutical CBD allows for achievement of comparable blood levels as opposed to artisanal, but is more expensive than artisanal products. So let's say that Kristen or caregiver are considering trying pharmaceutical CBD after you have the discussion with them after weighing treatment options. They're concerned about drug cost and ask you if an over-the-counter product or something they could get at a dispensary could be comparable. So practical considerations, and I think that this is a really important slide, and I have had this discussion on a daily basis for the past 10 years, comparing pharmaceutical grade CBD, which is now FDA approved for LGS, as well as Dravet syndrome and tuberous sclerosis complex, versus artisanal CBD and medical cannabis. So as you can see, the contents, we know that pharmaceutical grade CBD is 100 milligrams per mil, highly purified CBD. Every time one of my patients takes a dose of this medication, I know exactly what they're getting. as compared to the artisanal, which is typically a hemp product containing less than 0.3% THC, so enriched in CBD, versus medical cannabis, which is whole plant cannabis extracts containing a mix of cannabinoids, the terpenes, the other chemicals in the cannabis plant. Psychoactivity, we know that there is none. That's been shown in the clinical trials and testing that the FDA required. There's none with pharmaceutical grade CBD. It's possible with artisanal due to the presence of THC, and definitely likely in medical cannabis. Regulatory approval, again, the only FDA-approved formulation is the pharmaceutical grade. In fact, artisanal CBD is classified as an agricultural product, so it's not approved to treat or prevent any disease. And medical cannabis has variable and complex legal status, which varies on a state basis. Evidence for efficacy, multiple randomized controlled trials and real-world studies. So class 1 data for the pharmaceutical grade CBD, whereas for artisanal, it's not translatable to individual products. There's so much variability in the products and even between the product batches. And for medical cannabis, limited with safety concerns. Quality control, again, the FDA process demands and requires highly regulated, standardized production to guarantee purity, consistency, and accurate dosing, whereas there are no regulations for quality control for artisanal and medical cannabis. Access, the pharmaceutical grade CBD is the only that is now available by prescription through designated specialty pharmacies and covered in general by insurance. Artisanal CBD access is widely available, and medical cannabis legal and logistical barriers vary, again, state to state. And then the cost. Kind of when this pharmaceutical grade CBD came available, we had many patients who were taking the artisanal CBD. And one of the things that was kind of appealing to the families had been paying a lot of money out of pocket for that. And the fact that it was now covered by insurance was a big help for the family. And also there are patient assistance programs available if needed, whereas that is not true for the artisanal medical cannabis. So very different. And I think this is a conversation that I still have with my colleagues who are still trying to figure out the role of pharmaceutical grade CBD in treating epilepsy. So Tracy, I don't know, is this something you find in the LGS patient community? Are people pretty aware of these differences? And does it matter to people?
It does matter. I don't think people are aware of them as a whole, nor is the medical community, I think, fully aware of all of them. I think this cost comparison is really interesting because it is very expensive. The epilepsy is awful. We are trying to do something about it, so I don't fault people for trying to control their epilepsy, but I think there has become this tension in the community where families are feeling really judged if they are using artisanal CBD.
So to return to that, kind of clearly that would be false. As we've said, the artisanal CBD in one study had an average mean blood level of CBD less than half of pharmaceutical grade CBD with no reduction in seizures. And the pharma grade CBD group had a median 50% seizure reductions, suggesting that the higher levels of CBD, at least for many patients, might be more effective. And then also more expensive. Many of the artisanal CBD products have the same or greater cost per milligram as pharmaceutical CBD. And as we said, the pharmaceutical CBD should be covered by health insurance or through patient assistance programs for the approved indications, whereas this cannot be achieved with medical marijuana or artisanal CBD products, at least currently. So Tracy, how do you think when going to E of our share, with the ongoing regular reassessment of decision-making shared with patients, caregivers, primary care and specialists, and quality of life through the lifespan, as well as monitoring for treatment emergent AEs, how do you think that a primary care provider, because as you said, when you survey many people, that's who are taking care of our patients, how can a primary care provider or a pediatrician really have a role in the ongoing care of a patient for LGS?
Yeah, I think that's a great question. I think that at different times in the journey, we want different things, and we often think of it as a static, diagnosis that all caregivers can do something specific, right? All care providers can do something specific, but that's not true. In the beginning, we just want to know what it is and how to stop it. And why did it start if we are lucky enough to find out why? And then after somebody's failed, 5, 6, 7, 8 anti-seizure medicines, it starts to become about, how do we live with this? How are we going to cope? How can we get the best possible seizure care? Because we're now in the group of people who are very unlikely to get any sort of seizure control. How do we live a safe life, right? And then as you start to try and fail, you get up to 14 or 15 failed anti-seizure treatments, right? Now you're just like, okay, listen, how do we keep this kid alive, right? Like, how do we minimize hospital visits? How do we, try to minimize the amount of rescue medications that we have to use? How do we keep them on their learning path? I mean, I could stop my daughter's seizures by putting her in a coma, but then she has no quality of life whatsoever, right? So it really starts to very much become about quality of life. And then as the child ages and becomes an adult, you've got that whole transition, which is an issue. And so I think helping with the transition is really important. And then we often don't think about the transition from adult to aging adult, right? But they're prone to all these other diseases, the cancers, the dementia. And, there was just a paper that came out this week that was talking about how epilepsy ages the brain. And somebody with a developmental and epileptic encephalopathy within this cohort of, functional neuroimaging and brain aging has about an 18-year older brain than their age matched controls, right? And so they're experiencing aging at a much younger age. So I think thinking about it in the journey along that timeline, and where are the caregivers at? In most cases with LGS, the person with the disease is not able to speak for themselves, which is heartbreaking. I would rather make my own medical decisions than make them for somebody else. So I think caregivers carry this burden with them. And then, as they age, just don't give up. I don't know how many doctors have just given up on us completely. We can't give up, right? And you don't want to let seizures just lie. You don't want to let them just go unchecked. You do want to keep treating them and trying to bring them into check. But it really does start to become about quality of life as you get to the point where we're at, where my daughter is 31. So I think recognizing that evolution of the caregiver and the person with LGS is really important as well. They're going to want to go through a lot less procedures as they get older, and it's a lot harder to hold them down when they're older, right? So getting all of that diagnosis workup and surgery workup when they're young is important.
No, you're right. I think your comments, and I know comments you've made, and I know a big focus of the LGS Foundation is really not only on treating seizures, but improving overall quality of life. And so we know that the LGS impacts the quality of life, and like you said, long-term planning and management. So research on the impact of LGS on the patient's quality of life is actually really limited. And there are a couple of questionnaires that can be used with patients and caregivers, probably are not used enough. But as I think a study surveyed 65 adults with intellectual disability and epilepsy, and 135 adults with epilepsy without intellectual disability, plus caregivers, on the relative importance of the items from quality of life scales and health-related quality of life. I think, not surprisingly, was significantly lower in adults with IDDE. So the health-related quality of life domains identified as priorities by adults with IDDE. Seizure burden, as you said, can't give up. You've always got to strive to improve seizure control, even as people age from pediatrics into adults. Anti-seizure medication side effects, which probably become more significant in adults as people go on medications for other illnesses. The seizure unpredictability, I think, never goes away. And then I think the family impact. And the concerns valued significantly more among those with IDDE were family impact. I think you all have looked at this, the impact of having a family member with LGS on the whole family, the siblings, the parents, etc. Difficulty finding appropriately living conditions. We have transition workshops every few years in our program because this is such a struggle for families going through finding appropriate day programs when kids age out of school, finding living situations, particularly as parents are aging. Inadequate assistance, also an issue, I think, particularly as people transition into adulthood. And then that overall difficulty with transition from pediatric to adult care. And this was valued much more significantly among those with IDDE, kind of, I think, understandably. So then, Tracy, jumping back to your daughter's journey with LGS through adolescence and adulthood, can you discuss with us the real impact on LGS on Savannah and your family, and how it may look or how it has looked for you?
Yeah, absolutely. So I already talked about her beginning journey, which I think is, in some ways, when I look back, is one of the hardest times in the journey because it's all so new, and we're grieving the loss of a healthy child, right? But all of it's been equally awful. I don't think there's been a good part of the LGS journey that I can even comment on. But when you look back at just the vital statistics, and this is something that I just counted because it's all I could do, she would seize all the time. Between 5 and 18 years of age, she had more than 40,000 seizures. It took us 3 years to get the diagnosis of epilepsy. She had seen, it took us 15 years to find her etiology. She had seen 7 neurologists before we actually got the epilepsy diagnosis. So it wasn't just a single doctor not telling us she had epilepsy. It was multiple people not wanting to give us bad news. But if you have a ravenous mountain lion behind you and somebody tells you it's a kitty cat, I don't think you're doing that person any favor. And we did lose trust in the medical system for a while. By the time she was 18, she had tried and failed 26 anti-seizure treatments, including diets, medications, neuromodulators, surgery, and alternative therapies. She had 5 surgeries. She's getting rescue meds. At the age of 18, she was getting rescue meds 2 to 5 times a month. And she was going in to non-convulsive status epilepticus every week. And she has these sequential seizures that would start as tonic or tonic-clonic and then evolve into an atypical absence that just wouldn't end. And it was just really expensive overall. And so it's frustrating when you have doctors deciding, oh, they don't want to go on Felvital because of the risks associated with that, or they don't want to go on fenfluramine because, oh, they're going to have to get this, added test for their heart. I mean, anything is better than this nightmare. It was just absolute hell as we were going through this, right? And, when you look at the impact across all the different domains, those are listed here, but she was seizing all of the time at high risk of SUDEP. She was developing aspiration pneumonia frequently. I mean, she would get pneumonia about 4 or 5 times a year. She had behaviors, which we never knew if it was because she never learned that you can't lick people, or is it something to do with the seizures, right? Or is it part of her OCD, right? At 18, she couldn't read or write. Her speech was still slurred. She was still in diapers. She still needed a wheelchair about 70% of the time. She couldn't dress or feed or toilet herself, right? And then when you start to think about, none of us are sleeping, and she's got all these other issues, low bone density, social isolation, her liver problems because of all these meds, very, very thin. She's very, very skinny. It's hard to keep weight on her. And this impacts the whole family. I mean, it's just exhausting. I felt like there's no part of my life that's not impacted by this. And I remember when she was about 8 years old, I was in the grocery store and I was looking at the toilet paper aisle. And I just sat down on the floor in the grocery store and started crying because I couldn't even pick out toilet paper without considering LGS. They had to be flushable and they had to be wipes because she was trying to still learn at that point how to wipe herself, and she was going to throw it in the toilet. And she didn't know how to not be too abrasive. So they had to be wiped. So it's every aspect of your daily life. And we have this hierarchy of needs that we talk about in the LGS community, where if you remember Maslow's hierarchies of needs, you need food, clothing, water, air at the bottom in order to reach your, live your best life at the top. And for us, we're just trying to avoid crisis. And Savannah was one of the lucky ones. When she was 18 years old, I was doing my PhD and we tested her, did a whole exome sequencing on her. We found the cause of her seizures. And again, it's too much calcium going into her cells. So we put her on an off-label calcium channel blocker called verapamil. And within a couple of weeks, we saw this 95% reduction in seizures, which was huge because she was having about 300 seizures a month and she was going into status, remember, every week for the most part. And that just stopped. We had a huge reduction in that. And so she began to learn again, which was really beautiful. And she began to grow and develop. And so I think it's just really important to know to never give up, right? And now at 31, she's walking, she's talking, she's only in diapers at night, just in case she were to have a little bit of an accident, and we used to count words. It was oh, she spoke a 3-word sentence today. And now we stopped at 45 words. So I think it's a lesson in never giving up, but I don't ever want to go back to that hell that was surviving, trying to keep her safe and just coping.
It's an incredible journey that Savannah and your family has had. And I think your never give up is important. I mean, never give up. The lesson to us is never give up getting better seizure control. And also with, especially the effect of her starting on verapamil, never give up finding the etiology. And I think we also always need to remember that Lennox-Gastaut is not a single diagnosis. It's an epilepsy syndrome. It's not an etiology. and especially with her story with verapamil and knowing that, these other evolving therapies, medication and otherwise, if we can identify the etiology, what's causing our patients to have LGS, it could have a dramatic impact on the patient and their entire family and their world. So thank you for that, Tracy.
Absolutely. And I think more and more gene therapies are coming out, targeted treatments, more precision medicines, right? In addition, that are looking at off-label drugs or new drugs. And so the opportunities are only going to increase as you find the etiology. To be able to make those available to somebody is just crucial. It could be the matter of 300 seizures a month versus 2 seizures a month.
Yeah. So in conclusion, I think it's important to, again, consider the many disciplines. Looking at Tracy's list of Savannah's story that have major roles in caring for patients with LGS, I think it really takes a team. It's not, again, it's not treating seizures, it's taking care of the individual with LGS and their family. And those living with LGS will continue to have unique, complex, and lifelong neurological and medical needs. So needing definitely their medical team, the caregiving team, but also the therapists involved in optimizing their overall level of care and level of functioning. It takes a team, an important team, to optimize their world.
And I would just add right here, Elizabeth, that, I often think when I see images like this team-based approach to the management of LGS, you have the patient there in the center and they're kind of alone, right? They're kind of unsupported, right? Like doctors, we have our hospitals and we have, our professional societies and, and the caregivers, they can maybe find their support community. But for the patients and families, we are that at the LGS Foundation. We are their professional society, their support community that's really trying to bring them accurate, timely, scientific information to get the best care and the best treatment for their loved one.
Good point, Tracy. That should be a big bubble added to this figure. Because I like I said before, I think the patient advocacy groups, and I've seen the LGS Foundation just make a huge difference in the world of my patients and their families. So that bubble needs to be added here. And
added there. I wish we had had an LGS Foundation when Savannah was diagnosed. And I think most of us that are working there agree. We wish we had had one. And now there is one. And we've been here, 16 years and going strong. So it's great to be able to help end some of the social isolation that comes with this disease.
Yeah, I completely agree. So then summarizing our discussion with our SMART goals: specific, measurable, attainable, relevant, and timely. That's what we hope you'll take from this presentation to apply to your practice. That when using shared decision-making to individualize treatment plans for patients with LGS, incorporate the clinical trial data as well as real-world evidence alongside patient values and preferences. It's not just us treating the seizures, it's what the patients and families' goals are for the patient. And then to integrate a collaborative care approach that includes quality of life assessment with available measures, shared decision-making with patient and caregiver, and acknowledgement of the patient needs long-term care information into the treating plan to improve outcomes. So today's CMEO briefcase also complements another CMEO snack activity that we have: Guiding Lights, Managing Developmental Epileptic Encephalopathies, with a closer look at Lennox-Gastaut Syndrome, which discusses fundamentals of LGS and its impacts on patients. I hope you'll check out this stack as well. These activities and a wide variety of activities and resources on rare diseases like LGS are available on CME Outfitter's Rare Disease Education Hub. And to receive credit, CME or CE credit for this activity, participants must complete the post-test and evaluation online. Participants will be able to download and print their certificate immediately upon completion. So I'd like to thank you again, Tracy Dixon-Salvador, for joining me today and sharing your story and Savannah's story. And also thank you to our audience for joining us. Thank you also, CMEO, for making this possible. And be safe and take care of yourselves so you can provide the best care for your patients. Thank you.
Thank you.